Imagine for a second that you are waking up. It is a completely normal morning. You know, you stretch, you yawn, you throw your legs over the side of the bed.
Just a totally typical start to the day.
Right, exactly.
Yeah.
So you walk into the kitchen, you smell that fresh pot of coffee brewing,
Yeah.
and you reach out to pick up your favorite mug. But your hand? Well, your hand simply refuses to lift.
It just flops forward.
Yeah. It just hangs there from the wrist
Yeah.
like a dead weight.
Which, triggers this immediate visceral panic. Because your brain is sending the signal, right? You can feel the intention to move it.
But nothing happens.
Exactly. The machinery is just totally disconnected.
Right. You look at it in terror, and you try to squeeze your hand into a fist. And you find that you actually can close your fingers perfectly. The grip is still there. But the moment you try to open those fingers back up to grab the handle of the mug, nothing. The opening mechanism is completely gone.
It is a terrifying scenario for anyone. But from a diagnostic perspective, it's actually one of the most elegant mechanical puzzles in the human body.
Oh, absolutely.
We tend to think of human biology as this, this messy, unpredictable soup of cells and fluids.
Right.
But when you look closely at the peripheral nervous system, especially out in the arms and legs, it functions much less like a biological soup. It's much more like a highly precise, deeply logical system of pulleys and levers.
Like insulated electrical cables, right?
Exactly, like electrical cables.
And today, we are going incredibly deep into one very specific, very critical electrical cable. We have been reading through this fascinating postgraduate level medical script titled The Radial Nerve, Anatomy, Injury, and Treatment.
By Dr. Kumaran, yes.
Right. And the mission for this deep dive is to basically learn how to think like a neurosurgeon. We want to decode the engineering, the glaring evolutionary vulnerabilities, and just the pure mechanics of the human arm.
Because if you understand this one single nerve, you unlock the mechanical logic of your entire upper body.
It's wild. A skilled diagnostician doesn't even need like an X-ray or an MRI to figure out what's wrong in that coffee mug scenario, do they?
Oh, not at all. They can look at exactly which muscles are working and which are silent. And they can pinpoint a microscopic nerve injury down to a specific millimeter on your arm.
Just by looking.
Yeah. It is pure detective work based entirely on anatomical geography.
Okay, so to understand the detective work, we first have to understand the prime suspect. Or, well, rather, the victim.
The victim, yeah.
Dr. Kumaran's research introduces the radial nerve with this very grand, almost regal title. He calls it the great extensor of the upper limb.
A great extensor.
Yeah. So we need to talk about what extension actually means in human biomechanics, because we have multiple nerves running down our arms.
Right. There is the median nerve, the ulnar nerve, and the radial nerve.
And they completely divide up the labor.
They divide it based on a very strict binary system. In the human body, every single movement requires a counter movement. And this is a fundamental law of our physiology because of one simple, inescapable fact at the cellular level. Muscles can only pull. They are physically incapable of pushing.
Wait, hold on. You're saying muscles can never push? Like, at all?
Never. If you zoom in on a muscle fiber under a microscope, it's made of these tiny overlapping filaments. They're called actin and myosin.
Okay.
When a nerve sends an electrical spark, these filaments grab onto each other and they ratchet tightly together, shortening the muscle. They pull, but they have absolutely no biological spring mechanism to push themselves back apart. Once they contract, they are stuck in that shortened position.
Until an external force pulls them back out.
Exactly.
That is such a wild limitation when you really think about it. It is like having a car that only has a reverse gear.
That's a good way to put it.
Right. And if you want to go forward, you need a completely separate car hitched to the front to drag you the other way.
That is a perfect way to visualize it. So if you want to close your hand into a fist, which in medical terms is called flexion, you fire up the flexor muscles on the inside of your forearm.
And those are powered primarily by the median and ulnar nerves, right?
Yes. They pull your fingers inward. But once your hand is closed, those flexor muscles are, well, they're useless for opening it back up.
Because they can't push.
Exactly. You need an entirely separate system of muscles on the back of the forearm pulling in the exact opposite direction to drag those fingers straight again.
And that is extension.
That is extension. And in the upper limb, the radial nerve is the absolute undisputed master of extension. It is the great
A
opener.
great opener. So if the median and ulnar nerves are like the closing mechanism of an arcade claw on a
Oh,
shoe.
I like that.
Yeah, they grip the prize, right?
Yeah.
But the radial nerve is the mechanical spring that forces the claw back open so you can drop the prize and play again.
Exactly. Without the radial nerve, you just have a permanently closed hook. You can't straighten your elbow, you can't lift your wrist up against gravity, you can't open your fingers, and you can't pull your thumb outward to grasp something wide.
You're just left with half a machine.
Basically, yeah. The closing half works perfectly, but the opening half is completely unplugged.
Wow.
And this is why the physical architecture of this nerve is so critical. To understand how this opening signal gets all the way from your brain down to the tiny, delicate muscles of your thumb, we have to trace the actual physical cable.
From its power source down the arm.
Right. And when we trace that map, we immediately see exactly why this nerve is so notoriously vulnerable to injury.
Okay, let's look at the geography then. The text mentions that the radial nerve is the largest branch of the brachial plexus.
It is.
It carries nerve fibers from spinal levels C5 all the way down to T1. Now, brachial plexus sounds incredibly textbook. What does that actually look like if you were to, open someone up?
It looks like a chaotic, organic subway junction. I mean, imagine a bundle of thick, yellow, insulated cables exiting your spinal cord right in your neck.
Okay, picturing that.
They weave through the muscles of your neck, they dive under your collarbone, and they tangle together in this massive interchange, which is the brachial plexus.
Sounds messy.
It is. They swap fibers, reorganize themselves, and eventually, the largest, thickest bundle of wires emerges from the back of this interchange. And that is the radial nerve.
And it starts out safely tucked away, right? Down in the armpit, the axilla, as doctors call it.
Yes, the axilla. The armpit is a highly protected junction box deep inside the body. The radial nerve sits in there right behind the main artery of the arm.
But it can't just stay there.
No, it has a long way to go. Its destination is the back of the arm and the back of the forearm, where all those extensor muscles live.
Which means it has to travel. And this is where the journey gets treacherous. The nerve leaves the armpit, passes backward, and has to navigate around the humerus.
The big, thick bone of your upper arm.
Right? Now, reading this, I imagine it just floating through the meat of the arm.
Yeah.
But it doesn't.
No, not at all.
It actually wraps tightly around the back of the bone. It lies in a literal groove on the surface of the bone itself. The text calls it the spiral groove, or the radial groove.
Yes. And to make matters worse, it's sandwiched beneath the massive, heavy heads of the triceps muscle.
And it travels right alongside a major blood vessel.
Right. The profunda brachii, yes. Completely pinned against the bone.
I can't get over this. I have to call out human evolution for a second here.
Go full.
You are telling me that millions of years of evolution took the largest, thickest, most crucial nerve for opening our hands and placed it directly bare against a hard, unforgiving piece of bone.
In a shallow little ditch, yeah.
With the heaviest muscle in the arm pressing down on top of it. If an electrician ran a main power cable bare against a steel I-beam, right where heavy machinery presses down on it, they would lose their license immediately.
They definitely would. It certainly looks like a catastrophic design flaw from a pure engineering standpoint.
Total flaw.
But you have to remember the anatomical constraints. The nerve has to get from the inside of the armpit to the outside back of the elbow. The shortest, most mechanically efficient path is a spiral wrap around the cylinder of the bone. In normal circumstances, the triceps muscle actually provides a thick cushion of meat over the top, protecting the nerve from outside blunt force.
But the danger isn't necessarily from getting hit from the outside, is it?
No, the danger comes from the bone itself. The nerve is pressed bare against an anvil.
Oh, that sounds awful.
If any sustained external pressure compresses that nerve against the hard bone of the spiral groove, the nerve has nowhere to sink into. It can't escape.
It just gets crushed.
Exactly, crushed between two hard surfaces.
And we are definitely going to get into the specific and honestly bizarre ways people accidentally crush this nerve against that bone in their sleep.
There are some classic stories.
But let's finish tracing the route down the arm first. Because the nerve doesn't just stay a single thick trunk for its whole journey.
No, it doesn't.
As it moves past this vulnerable bone and gets down toward the elbow, it essentially realizes that it has too many different jobs to do in the hand, so it has to split.
It reaches a major fork in the road. The nerve pierces through a wall of tough, gristly connective tissue called the lateral intermuscular septum.
Which is basically a wall separating the back of the arm from the front, right?
Exactly. It slips into the front of the elbow joint right around the lateral epicondyle, which is that bony bump on the outside of your elbow.
Right, I could feel that.
And right there, it divides into two completely distinct terminal branches.
It separates the feeling from the moving?
It fully segregates its functions, yes. One branch becomes the superficial branch. This is purely sensory. It contains absolutely no motor wires at all.
Just feeling.
Right. It's just a data cable running straight down the forearm, right under the skin, to provide the sense of touch to the back of your hand.
And the other one?
The other branch is the deep branch. This one is purely motor. No sensory wires. Its only job is to carry electrical commands from the brain to make muscles contract.
But to reach the extensor muscles buried on the back of the forearm, this deep branch has to dive deep into the tissue.
It does.
And reading Dr. Senthil Kumaran's text, it mentioned a very specific anatomical structure here that sounds like a location in an Indiana Jones movie.
Let me guess. The arcade of Fruss.
Yes. It says the deep motor branch dives through the supinator muscle, passing under a fibrous edge called the arcade of Fruss.
The arcade of Fruss. It is a beautifully dramatic name for what is essentially biological choke point.
A choke point.
Yeah. Nerves are soft, delicate, almost fat-like structures. Muscles, on the other hand, are powerful, dense, and encased in tough, rigid, fibrous sheaths.
It's a tight squeeze.
Very tight. When a nerve has to physically pass through a muscle or under a tight archway of fibrous tissue like this arcade, it's literally threading a needle. If that surrounding muscle gets inflamed from overuse, or if a tiny cyst grows nearby, that tight archway suddenly becomes a guillotine.
Yikes. So the deep branch squeezes under this arcade of Fruss, merges on the other side, and actually gets a name change.
It does, yes.
It's now called the posterior interosseous nerve.
Yeah.
And this is the undisputed boss of the forearm.
The absolute boss.
It powers all the muscles that pull the wrist up, straighten the knuckles, and extend the thumb.
Yes. And this strict separation of duties, the sensory branch staying shallow and going one way, the motor branch diving deep through a choke point going the other way, is exactly why diagnosticians love examining the radial nerve.
Because it isolates the variables.
Exactly that. If a patient comes into the clinic and says, "Doctor, I can't lift my fingers at all, but I can feel a pinprick on the back of my hand perfectly fine," well, the doctor instantly knows something.
They know the main trunk of the radial nerve up in the arm is perfectly healthy.
Right. The blockage must be isolated strictly to the deep motor branch, almost certainly trapped right there at the arcade of Fruss.
Okay, I want to unpack this concept of pinpointing the damage, because the source text gives us what is essentially a literal electrical map of the arm.
It's a great map.
It details the exact order in which the radial nerve plugs into different muscles as it travels from top to bottom. I keep thinking of it like a fuse box in a house.
The fuse box analogy holds up perfectly here. Walk me through how you are visualizing it.
Okay, imagine the radial nerve is the main power line coming from the street into a multi-story house.
Okay.
The house is your arm. The power line comes into the top floor of the armpit and immediately gives off a subwire to power the triceps muscle.
The triceps, yes. The muscle on the back of your upper arm that straightens your elbow.
So triceps gets power first, right at the top floor.
And critically, the triceps gets its power before the main nerve enters that dangerous spiral groove we talked about.
Right. So then the main power line continues down a level, travels through the dangerous spiral groove, crosses the elbow, and gives off a wire to the brachioradialis and the long radial wrist extensor.
Which help bend the elbow in certain positions and pull the wrist up.
Right. Then the main line goes down to the basement, that deep branch, squeezing through the arcade of Fruss, and powers the supinator, the finger extensors, and the thumb extensor.
Down in the basement, yep.
And finally, there's that purely sensory wire running outside the house all the way down to the back of the hand, specifically to an area called the anatomical snuff box.
Ah, the anatomical snuff box. Let's actually have everyone listening find this on themselves right now.
Oh yes. Listener, if you are not driving, hold your hand out in front of you.
Splay your fingers wide and pull your thumb out as far away from your index finger as you can, pointing it toward the ceiling.
Oh, okay. Doing it.
If you look at the base of your thumb, right where it meets your wrist, you will see two prominent tendons pop up, creating a small triangular depression or hollow between them.
It looks like a little skin bowl.
Yeah.
Historically, people would place powdered tobacco or snuff into that little depression to snort it, which is how it got the name.
Hence the name. But neurologically, that exact patch of skin inside that little bowl is incredibly important.
Why is that?
It is the radial nerve's autonomous zone. It is the only patch of skin on the entire human body where the radial nerve is the sole exclusive provider of sensation.
Wow, the only spot.
Yes. Everywhere else, the median or ulnar nerves kind of overlap and help out, but the snuff box is purely radial.
So it's the ultimate test area.
Exactly. If a doctor takes a piece of cotton and touches that specific triangle and you can't feel it, your radial sensory wire is definitively offline.
So applying the fuse box analogy.
Yep.
If you blow the main breaker at the very top of the house, up in the armpit, the whole house goes dark.
Complete blackout.
Triceps loses power, wrist loses power, fingers lose power, and the snuff box goes totally numb. But if you blow a subpanel further down the line, say right at the elbow,
The triceps up on the top floor still has power because its wire branched off higher up.
but everything below the elbow goes dark.
This is how a neurologist literally reads the body. The patient's physical deficits act as a living circuit diagram.
It's so cool.
You ask them to push against you to test the triceps. If it's strong, you know the lesion is below the armpit.
Right.
You ask them to lift their wrist. If they can lift the wrist, but the fingers are completely limp, you know the lesion is below the elbow, likely at that arcade of Frost.
By methodically checking which rooms in the house still have power, you can trace the invisible wire down the arm until you find the exact millimeter where the electrical current stops.
Precisely. It is incredibly elegant.
It really is. But to truly read that circuit diagram when things go wrong, we first need to understand the language of the damage itself.
Because it's not always a cleanly cut wire.
Right. Sometimes the wire is just bruised or choked. Dr. Senhil Kumaran's text outlines a specific grading system for nerve injuries called Seddon's classification.
Seddon's classification is the bedrock of neurosurgery.
Let's get into it.
To the patient, a nerve injury just feels like paralysis. The arm won't move, and they are terrified. But internally, the biological reality of why the signal isn't getting through dictates everything.
It dictates the future.
Exactly. It dictates whether they will wake up fully healed next week, slowly recover over a year, or require major surgery.
Let's walk through the three types Seddon laid out. The first and least severe is called neuropraxia.
Neuropraxia, yes.
The text describes this as a conduction block with the axon intact. What is actually happening inside the arm here?
Think of a single nerve fiber as a microscopic copper wire that's the axon, and it's wrapped in a thick, fatty rubber insulation called the myelin sheath.
Okay, copper wire, rubber insulation. Got it.
In neuropraxia, the nerve has usually been compressed or stretched slightly. Think of it like stepping heavily on a garden hose.
So the structure is fine.
Yes, the physical structure of the axon is perfectly fine. It hasn't been cut or snapped.
But the pressure does something.
Right. The immense pressure has squeezed the tiny blood vessels that feed the nerve, causing local ischemia, meaning a lack of oxygen.
So the nerve is literally suffocating.
It suffocates, and that stress scrambles the fatty insulation around the wire.
Oh, wow.
The brain sends the electrical spark down the axon to open the hand, but when the spark hits that compressed, uninsulated zone, it just fizzles out. It stops.
But it can heal, right?
The absolute beauty of neuropraxia is that once you remove the pressure and the blood flow returns, the local cells repair the insulation. The nerve wakes back up.
And how long does that take?
Recovery is spontaneous and 100% complete, taking anywhere from a few hours to a few weeks.
Okay, so neuropraxia is a pinched hose. The second grade is axonotmesis. The text defines this as loss of the axon with its guiding tube preserved.
This one is significantly darker.
It sounds biologically much darker.
In axonotmesis, the trauma is forceful enough, maybe a severe crush injury, or the bone breaks and violently stretches the nerve that the internal copper wire, the axon itself, actually snaps. It violently breaks in half. The electrical connection is completely physically severed.
But the text says the guiding tube is preserved. Why does that matter if the actual wire inside is broken?
To understand this, you have to understand one of the craziest biological realities of the human body.
I love these.
A single nerve cell body lives way up in your spinal cord. Its axon is essentially a single, incredibly long, microscopic tentacle reaching all the way down your arm to a muscle in your hand.
It's a single cell that can be 3 feet long.
Yes, one single cell.
That is mind-blowing.
So if that tentacle snaps in the middle of your upper arm, the disconnected piece of the tentacle below the break instantly dies.
Because it's cut off from the main body.
Right. Over a couple of weeks, it actually disintegrates and rots away in a process called Wallerian degeneration. Macrophages, the body's garbage men, come in and eat the dead wire.
Wow, so half the wire just turns to mush and is eaten.
But the cell body up in the spinal cord is still very much alive, and it realizes its tentacle has been cut.
So it tries to fix it.
Exactly. It immediately starts trying to grow a new tentacle. It sprouts a microscopic, raw electrical tip that starts pushing its way down the arm.
But how does it know where to go? I mean, how does that microscopic sprout originating in the shoulder find its way through a foot of muscle, fat, and bone to plug back into one specific muscle fiber in the thumb?
Oh, it uses the tube.
It uses the tube.
Yes. Even though the inside wire snapped and died, the tough outer connective tissue sheath, the biological tunnel, didn't break.
So it's like an empty conduit.
Exactly.
Yeah.
So the new regenerating axon sprout finds the opening of that empty tunnel, and it just starts growing down the inside of it millimeter by millimeter, following the pre-laid tracks until it finally reaches the muscle and reestablishes the connection.
The text notes this growth happens at a rate of roughly 1 millimeter per day. That is tiny. That's about an inch a month.
An inch a month. So if you snap the axon up near your armpit, and it has to grow all the way down at the arcata fros in your forearm, let's say that's 12 inches.
That is a full calendar year.
12 solid months of waiting, doing physical therapy, while an invisible microscopic wire slowly snakes its way down a tube inside your arm.
It requires immense patience. But the silver lining is, as long as that outer tube is intact, the GPS coordinates are saved.
The nerve will eventually find its home.
Which brings us to the third and most devastating grade of injury, neuromesis. The text simply calls it complete division.
This is the absolute worst-case scenario.
Someone took a pair of shears.
Or a jagged piece of fractured bone acted like a knife and cut the entire cable clean in half. The internal copper axons are severed, and the external guiding tubes are completely torn apart.
So the whole thing is physically separated into two disconnected stumps.
Yes. So even if the live cell body tries to sprout new growth, it has no tunnel to follow. The GPS is destroyed.
So what happens to the sprouts?
They push out of the top stump, but they just hit a void. They get lost in the surrounding blood and scar tissue.
That sounds awful.
It is. They curl back on themselves and form this painful, highly sensitive, tangled ball of raw nerve endings called a neuroma.
So it will never heal on its own.
A neuromesis injury will never, ever heal on its own. It absolutely mandates a surgeon going in, locating the two severed stumps, and painstakingly sewing the microscopic tubes back together under a high-powered microscope.
Just so the sprout and the axons have a path to cross the gap.
Exactly.
Okay, so that's the pathology. But Dr. Senthil Kumaran notes that most closed radial nerve palsies, meaning injuries where the skin isn't broken and a knife isn't involved, are just mild neuropraxias.
Yes, the garden hose being stepped on.
The wire is fine, it's just choked. And this completely dictates how a doctor treats it, which is usually just waiting for it to wake up.
Right.
But what actually causes these injuries in the real world? This is where the medical literature gets incredibly human.
Oh, totally. The names of these injury zones tell such deeply relatable stories.
They are a perfect intersection of human behavior and anatomical vulnerability.
Let's walk down the arm again, looking at the real-world traps waiting for the radial nerve.
Starting at the top.
Right up at the top floor, in the armpit, the classic injury is called crutch palsy.
I can visualize this perfectly. You break your ankle, you're handed a pair of poorly fitted wooden crutches, and your instinct is to lean your entire body weight directly onto the top pads,
wedging them deep up into your armpits. But as we established, the brachial plexus and the radial nerve are sitting right there.
so you're crushing them.
You are essentially taking a hard wooden stick and using the weight of your own body to crush the radial nerve against the humerus bone.
And because the injury is so high up, you blow the main breaker. You lose the triceps, the wrist, the fingers, the snuff box sensation, everything.
This is why physical therapists will relentlessly correct you to bear your weight on your hands when using crutches, never your armpits.
That makes total sense. But as we move down to the middle of the arm, down to that highly vulnerable spiral groove we talked about earlier, we encounter what has to be the most famous and most interestingly named radial nerve syndromes in all of medicine.
Ah, yes, Saturday night palsy.
Saturday night palsy, and its romantic cousin, honeymoon palsy. Tell me exactly what a Saturday night palsy is.
Picture a Saturday night at a bar. Someone has had a significant amount to drink enough to fall into a heavy, unnaturally deep, unmoving sleep.
Okay, they're passed out.
Right. They pass out sitting in a wooden chair, but they happen to drape their arm over the hard top edge of the chair back, and they stay completely motionless in that exact posture for 6, maybe 8 hours.
Which a sober person would never do.
Right.
If I fall asleep on my arm and it starts to tingle, my brain wakes me up just enough to shift positions.
Exactly. You have a natural nociceptive feedback loop. Pain tells you to move.
But heavy intoxication suppresses that.
It suppresses that protective brain response. So the hard wooden edge of the chair presses directly into the back of the arm, right into that shallow spiral groove, compressing the radial nerve against the humerus bone for hours on end.
So the nerve suffocates.
The tiny blood vessels supplying the nerve are squeezed shut, the nerve suffocates, the Schwann cells that maintain the myelin insulation start to fail.
And the patient wakes up Sunday morning, hungover, only to find their hand hanging completely limp.
It's terrifying.
They try to open their fingers, and nothing happens. It must feel like they've had a stroke.
It is terrifying for the patient. And honeymoon palsy operates on the exact same mechanical principle.
How does that one work?
Instead of a chair back, it's a romantic partner falling asleep with their heavy head resting squarely on your outstretched upper arm.
Oh, that's sweet.
Until it's not.
Right. You don't want to wake them, so you lie perfectly still all night? By morning, the weight of their skull has crushed your radial nerve against the spiral groove.
But the good news here, based on Seddon's classification, is that this is almost always just a neuropraxia, right?
Yes.
The axon hasn't snapped, the tube hasn't torn, it's just heavily bruised insulation.
Correct. Once the pressure is relieved, the nerve will almost always fully recover on its own. It might take 3 days or it might take 3 months for the myelin to repair itself, but the copper wiring is completely intact. The text mentions a crucial clinical sign for these middle-of-the-arm spiral groove injuries. When someone wakes up with Saturday night palsy, their wrist drops, their fingers are paralyzed, but their triceps muscle still works perfectly.
Yes, it does.
They can punch their arms straight out. Why is the triceps spared if the whole arm was crushed?
Because of our fuse box map, the branch of the nerve that powers the triceps leaves the main trunk above the spiral groove.
Ah, so it branches off earlier.
Exactly. So by the time the main nerve travels down and gets crushed by the chair back, the triceps has already safely received its power supply higher up the line.
Which is a huge clue for the doctor.
It's a massive clue. If the triceps works but the wrist doesn't, the doctor instantly knows the injury isn't in the armpit. It's right there in the middle of the arm.
Okay, there is a postgraduate level clinical point noted here for middle-of-the-arm injuries. Not all of them are caused by deep sleep.
No, some are much worse.
Some are caused by massive violent trauma. The text specifically highlights a Holstein-Lewis fracture. What is going on there?
Well, the humerus is a very thick bone, but it can break. A Holstein-Lewis fracture is a highly specific type of break in the lower third of the humerus. It is a spiral fracture.
Meaning it twists.
Yes, the bone violently twists until it snaps, creating incredibly sharp, jagged, corkscrew-like bone spikes.
That sounds horrific.
The reason this specific fracture is famous and deeply feared by orthopedic surgeons is because the fracture line occurs precisely at the spot where the radial nerve is tightly tethered to the bone.
Right, as it pierces through that tough intramuscular septum wall we talked about earlier.
Exactly.
So the nerve is essentially glued down right across the fault line of a jagged earthquake.
It couldn't be in a worse position. When the bone snaps and the fragments shift, the nerve is routinely caught between the jagged bone ends.
Oh, no.
It can get violently stretched, crushed, or completely sheared in half a full neuromesis.
And the text notes a terrifying scenario for doctors here. Imagine a patient comes into the ER with a broken humerus.
Yeah.
The doctor checks their hand, and the patient can lift their wrist and open their fingers perfectly.
Right. The radial nerve is safe.
Then, the doctor sedates the patient and forcefully pulls and manipulates the arm to set the broken bone back straight.
Yes. They wake the patient up, put them in a cast, and say, okay, lift your fingers, and the patient can't. The wrist drops.
What just happened?
The doctor accidentally grabbed the nerve with the bone shards while twisting the arm back into place.
The doctor actively trapped the nerve inside the fracture site.
They did. This is a surgical emergency. The doctor cannot wait and see. They have to rush the patient to the operating room, cut the arm open, pry the bone fragments apart, and physically extract the trapped nerve before the bone heals around it and destroys it forever.
The stakes are just incredibly high. Let's keep tracing down the arm. We move past the elbow and enter the upper forearm.
Down into the basement.
Right. The nerve has split, and we are now tracking the deep motor branch as it dives through that fibrous choke point, the arcade of Fros. What takes out the nerve down in the basement?
Down here, we occasionally see trauma like a severe dislocation of the elbow stretching the nerve. But more often, we see insidious, slow-moving space issues.
Space issues. like a tumor.
Right. The text mentions masses like a lipoma, which is a benign tumor made of fat cells, or a ganglion cyst.
Oh, I've heard of those.
If a lump slowly grows deep inside the muscle tissue right next to the arcade of Froese, it gradually squishes the deep branch of the nerve against that fibrous archway.
And the source material highlights a really important nuanced distinction here. It says diagnosticians have to distinguish between posterior interosseous nerve syndrome, or PINE syndrome, and radial tunnel syndrome.
Yes.
They sound identical and they happen in the exact same spot, but they manifest entirely differently.
They occur at the exact same geographical choke point, but the nature of the pinch creates a totally different clinical picture.
How so?
PN syndrome is a true motor palsy. The deep nerve is squeezed hard enough that the electrical signals to the muscles are definitively blocked. The patient experiences weakness.
Specifically, they can't lift their fingers, right? They get finger drop.
Yes, but crucially notice this. They might still be able to lift their wrist.
Why?
Because the specific nerve branch that powers the long wrist extensor muscle often branches off just above the pinch point.
Wow, geography again.
Exactly. And because the sensory branch is totally segregated on the other side of the arm, they have absolutely no numbness.
Okay, so PAN syndrome is painless weakness. What is radial tunnel syndrome?
Radial tunnel syndrome is purely a pain syndrome. The nerve is being chafed or lightly compressed, but not squeezed hard enough to block the motor signal.
So there's no weakness and no numbness.
It's just deep, chronic, burning pain over the upper forearm. And here's the diagnostic trap. This pain occurs in the exact same spot on the elbow where people get tennis elbow.
Tennis elbow, which is a completely different issue.
Right. It's an inflammation of the muscle tendon itself. Oh, wow. So you could have a patient come in complaining of elbow pain, and you diagnose them with tennis elbow, give them cortisone shots, tell them to stretch, and it does absolutely nothing because they actually have a deeply buried nerve being slowly strangled.
It happens all the time.
Yeah.
It requires a very astute clinician to recognize that the pain is neurological, not muscular.
Let's move down to the very end of the line, the final injury zone, all the way down at the wrist.
The end of the road.
We are looking exclusively at the superficial sensory branch now. The text calls this Wartenberg syndrome, or by its much cooler Latin name, Chiralgia paresthetica. What causes this?
This is perhaps the most mechanically straightforward of all the syndromes. That superficial sensory branch runs right under the skin on the thumb side of the wrist, directly over the hard wrist bones.
So it's right near the surface.
Yes. If you wear a wristwatch that is ratcheted down way too tight, or heavy, tight bracelets, or, as the medical literature explicitly points out, metal handcuffs that are applied too forcefully during an arrest, you physically crush that superficial sensory nerve against the bone. And because this specific branch contains 0 motor wires, the result is purely sensory.
Purely sensory.
You don't get weakness.
Yeah.
You don't get wrist drop. You just get a totally numb patch of skin over the back of your thumb and hand.
It is the ultimate proof of how perfectly segregated the arm's wiring system becomes at the end of the line.
The geography dictates the symptoms flawlessly, which leads us to the most defining, iconic symptom of all.
Wrist drop.
When that main trunk of the radial nerve gets pinched higher up, we get the signature sign of this condition, wrist drop. But Dr. Senthilkumaran's text outlines a mechanical paradox regarding wrist drop that completely baffles almost every medical student the first time they see it in the clinic.
Oh, yes. This is the mechanical haha moment.
So we know wrist drop happens because the extensor muscles on the back of the arm are unplugged. They can't pull the hand up, so gravity takes over. And the hand, the fingers, and the thumb all sag downward toward the floor.
It looks like a swan's neck.
But the text points out a massive secondary consequence. The patient has a surprisingly weak grip. Their grip strength completely plummets. They can barely squeeze your fingers.
And this is where the medical student usually freezes in confusion.
Because we just spent the entire first segment of this deep dive establishing that gripping, closing the hand into a fist, is controlled entirely by the flexor muscles on the inside of the forearm.
Exactly.
And those flexor muscles are powered by the median and ulnar nerves, which are 100% perfectly healthy in a radial nerve injury.
The closing mechanism has full electrical power.
So why can't the patient make a strong fist?
I absolutely love this explanation because it's not biology, it's pure physics. Imagine the flexor muscles are trying to pull a rope.
Okay, visualizing a rope.
But instead of standing on solid ground to pull the rope, you are standing on a sheet of smooth ice.
Oh,
You can be the strongest person in the world, your biceps can be massive, but if you don't have an anchor point, you have absolutely zero leverage. You pull the rope and you just slide forward on the ice. The energy goes nowhere.
that is a brilliant analogy. To generate a powerful grip, your finger flexor muscles need immense mechanical tension.
Try this. When you squeeze an object as hard as you possibly can, pay attention to what your wrist naturally does.
Okay, I'm squeezing. It bends backward, it extends.
By pulling the wrist backward into extension, your body tightly stretches the flexor tendons across the palm, essentially tightening the ropes. It gives the flexor muscles massive mechanical tension to snap the fingers shut forcefully.
But if your wrist is flopped fully forward, which is what happens in wrist drop, those flexor tendons become completely slack. They are loose.
Precisely. When the flexor muscle contracts, it spends all of its biological energy just taking up the slack in the loose tendon, leaving almost zero force left over to actually squeeze the object.
It is exactly like trying to squeeze the handbrake on a bicycle when the brake cable is 2 inches too long.
Oh, exactly like that.
You squeeze the lever all the way to the handlebar, the cable pulls, but the brake pads barely even touch the wheel. The muscle works, but the mechanical leverage is completely broken.
What's fascinating here is how easy it is to prove this physics lesson to a terrified patient. A patient is sitting in your office in despair because their hand feels entirely useless.
He can't even hold a paper cup.
Right. The doctor simply takes a rigid piece of plastic, a basic splint, places it under the forearm, and physically props the patient's limp wrist up into a straight, extended position.
You restore the anchor point.
You give them solid ground to stand on. Suddenly, the flexor tendons are pulled taut. The tension is restored. The doctor asks the patient to squeeze their hand and boom. Their grip strength is instantly, magically back to normal.
It completely blows their mind.
It proves that treating peripheral nerve injuries isn't just about prescribing pills or waiting for biology. It is fundamentally about engineering and biomechanics.
You restore the physical anchor, you restore the function. But before you just slap a piece of plastic on someone's arm and send them home, you have to formally diagnose them. How does a doctor actually prove exactly what's happening and where the blockage is?
The clinical examination is a master class in applied anatomy. The doctor literally walks down the nerve, testing each muscle one by one in the exact anatomical order that the nerve supplies them.
Right. The text lays out the sequence. First, you test the top floor, you test the triceps, you ask the patient to straighten their elbow against resistance while you try to push it bent.
And if they can fight you and keep it straight, the triceps is online. The lesion must be below the armpit.
Then you move down to the next branch point. You test the brachioradialis. This is very cool, very specific muscle test.
It's one of my favorites to demonstrate.
The brachioradialis is a thick muscle on the thumb side of the forearm that helps bend the elbow, but only when the arm is in a very specific rotation. The text says to test it by flexing the elbow with the forearm midway between pronation and supination.
Let's translate that. I want everyone listening to try this test on themselves right now. Put your right arm out in front of you. Bend your elbow to 90 degrees, like your arm is in a sling.
Okay, bent to 90 degrees.
Now, rotate your hand so your thumb is pointing straight up at the ceiling. Not palm up, not palm down. Thumb pointing straight up, like you're holding a heavy beer mug.
Got the mug.
Now, take your left hand and push down hard on your right wrist while you use your right arm to resist and try to pull your wrist up toward your shoulder.
If you do that forcefully, and you look at the top edge of your right forearm, right near the elbow joint, you will see a large, thick band of muscle suddenly bulge out and stand up sharply under the skin.
That is your brachioradialis firing.
It's surprisingly prominent once you know how to pop it out. So the doctor asks the patient to do that, and that muscle pops up. The nerve signal has successfully made it past the dangerous spiral groove and crossed the elbow.
And if the arm is flat and the muscle is silent, the electrical signal is blocked higher up in the arm.
The doctor continues this methodical process down the arm, testing the wrist extensor, testing the finger knuckles, testing the thumb's ability to pull outward.
And finally, they map the sensory loss, taking a small pin and lightly touching that anatomical snuff box.
But beyond just testing muscles, there's a physical trick doctors use that the text mentions. It's called Tinel's sign.
Tinel's sign.
I was so intrigued by this.
Yeah.
It sounds like playing a percussion instrument on the patient.
It essentially is. When a nerve is injured, specifically when it has been crushed, and it's actively trying to regenerate and grow new microscopic axons down those empty tubes, The growing tips of those new nerve fibers are incredibly hypersensitive.
How hypersensitive?
They are essentially raw, uninsulated electrical live wires pushing through the tissue.
So what happens if you tap them?
If the doctor takes their finger and lightly taps on the skin directly over where that injured nerve is trying to heal, the physical tap triggers the raw nerve endings. The patient will feel a sudden, shocking zap of electricity like a jolt of lightning or severe pins and needles shooting down their arm directly into their hand.
Wow, that zap is a positive Tinel sign.
Yes.
You are literally tapping the outside of the cable to see where the internal wire is exposed and raw.
Yes. Doctors use it initially to locate the exact site of the crush injury, but far more importantly, they use it over time to track the physical recovery of the nerve.
Remember, we said the nerve grows at 1 millimeter a day?
An inch a month.
Right. So the doctor can tap the arm month after month. In January, tapping the elbow causes a shock. In February, tapping the elbow does nothing, but tapping 2 inches lower down the forearm causes the shock.
By tracking that advancing front of electricity down the arm, the doctor can literally trace the biological repair crew moving down the tunnel in real time.
That is just incredible. You are physically tracking a cellular process from the outside of the body. Now, the text also mentions high-tech investigations beyond just tapping and pushing.
Nerve conduction studies and EMG.
Right. EMG stands for electromyography. This is where they stick needles into your muscles and measure the electrical current, right?
Yes, an EMG is exactly like an electrician using a multimeter to test a house's internal wiring. They insert a fine needle electrode directly into the muscle belly.
Sounds uncomfortable.
It's not a massage, that's for sure. Then they send a tiny electrical shock into the nerve higher up the arm, and the machine measures exactly how long it takes for that shock to reach the muscle at the bottom.
What does that actually look and sound like in the clinic?
It is an intense experience. The machine translates the electrical activity of your muscle into audio. When a healthy muscle contracts, it sounds like a low, rumbling thrum on the machine's speaker.
A thrum, okay.
But if a muscle has lost its nerve supply, it gets desperate. The muscle fibers start spontaneously misfiring, essentially crying out for a signal.
And what does that sound like?
On the EMG machine, this sounds like high-pitched static or rain hitting a tin roof. It is called fibrillation. If the doctor hears that static, they know the nerve wire is definitively cut or severely blocked.
But the text includes a massive vital caveat for this test.
Yeah.
It says, these electrical changes, the fibrillation, take 2 to 3 weeks to appear after an acute injury. Wait, why?
It's unintuitive, isn't it?
It is. If I take scissors and cut the power cord to a lamp, the lamp goes out instantly. Why does it take 3 weeks for the medical machine to show the wire is cut?
Because of the biology of Lawlerian degeneration we discussed earlier, if you cut a nerve in half, yes, the muscle is paralyzed instantly. The brain's signal cannot cross the gap.
Right.
But the disconnected piece of nerve below the cut doesn't magically vanish into thin air. It sits there, full of neurotransmitters, slowly dying.
Oh, I see.
It takes about 2 to 3 full weeks for that severed piece of nerve to physically disintegrate and rot away, and for the muscle fibers to realize they are truly abandoned and start fibrillating in panic.
Ah, so if you do the test too early, it lies to you.
Exactly. If you do an EMG on day 2 after a severe car crash, the severed nerve stub inside the arm might still be biologically fresh enough to conduct a local shock from the needle, giving the doctor a falsely reassuring reading.
The machine says the nerve conducts, but the nerve is actually cut in half higher up.
You have to wait for the disconnected wires to rot away before the test becomes definitively accurate.
Okay, so the waiting period passes, the diagnosis is made, the level of the injury is perfectly mapped on the arm. We know if it's a Saturday night squeeze or a violent Holstein-Lewis bone trap.
Now we arrive at the most crucial juncture for the patient.
Do we wait patiently, or do we cut the arm open?
This is where clinical judgment separates the textbooks from the real world. The primary treatment for the vast majority of closed injuries, the Saturday night palsies, the blunt traumas, is conservative.
It is simply patience.
As we established, these are mostly neuropraxias. The internal guiding tubes are intact, the nerve will recover.
So no surgery.
The doctor's job is not to miraculously fix the nerve, because the body's cells will do that. The doctor's job is to protect the limb while the body does the slow work.
And the primary tool for that protection is that cock-up wrist splint we talked about earlier. It holds the wrist extended, restoring the anchor point so they can use their grip strength to eat and work. But Dr. Senthilkumar notes another, far more sinister reason for the splint. He writes that it prevents the unopposed flexors from pulling the wrist into a fixed contracture. What does that mean?
It has to do with muscle resting cone. Even when you are completely relaxed, your muscles are never truly off. They maintain a slight constant tension.
Like a standby mode.
Yes. In a healthy arm, the flexors are constantly pulling slightly inward, and the extensors are constantly pulling slightly outward. They balance each other out in a perfect biological stalemate.
But if the radial nerve dies,
Yeah.
the extensors just shut off completely. They drop the rope.
Yes. Suddenly, the flexors on the inside of the arm are pulling with no opposition whatsoever. Over weeks and months, those unopposed flexor muscles will slowly, relentlessly drag the wrist downward and curl the fingers inward into a tight fist.
Oh, wow.
And if the hand is left in that position for months while waiting for the nerve to heal, the ligaments and joints will actually adapt. They will shrink, freeze, and fuse into that twisted, claw-like position permanently. That is a contracture.
So even if the radial nerve finally heals a year later and the muscles wake up, it won't matter because the actual hinges of the hand are rested shut.
Precisely. The splint physically holds the wrist back, constantly fighting the flexors, keeping the joints stretched, supple, and aligned.
And you add daily physical therapy to keep everything moving.
Right, so that when the neurological power finally comes back online, the mechanical machinery is still well-oiled and ready to operate.
It's like putting blocks under the frame of a car if you're leaving it parked in a garage for a year so the suspension doesn't permanently warp under its own weight.
Perfect analogy.
So you splint it, you do therapy, and you just watch that Tiddles sign slowly tap its way down the arm. But what if it doesn't? What if the tap never moves?
Then you have a problem.
The text notes a very specific, hard threshold that triggers a surgeon to stop waiting and start cutting.
Surgery is obviously immediately indicated for catastrophic traumas, an open wound from a knife where the nerve is visibly sliced, or a rapidly expanding tumor. But for a closed, blunt injury where you are playing the waiting game, the text sets a critical biological ticking clock. Around 3 to 4 months.
3 to 4 months.
If a closed palsy shows absolutely zero clinical signs of recovery, and the EMG shows zero electrical regeneration by 3 months, you must open the arm.
Why 3 months? Why not give it 6 months or a year, just to be extremely safe? If it grows an inch a month, maybe it just has a long way to go.
Because of muscle atrophy. When a muscle loses its nerve supply, it doesn't just sit there frozen in time waiting for the power to return.
What happens to it?
Without that constant electrical stimulation, the muscle begins to digest itself. The muscle fibers shrink, they wither, and the healthy, contracting muscle tissue is slowly, irreversibly replaced by useless fat and fibrotic scar tissue.
Oh, wow. So the motor is essentially rusting away.
Yes. If you wait a year for a nerve to regenerate down the arm, the nerve might finally reach its destination. But there won't be any muscle left to plug into. It will just be plugging into a lump of fat.
So the 3-month mark is the critical window.
It is where a surgeon has to say, the nerve isn't healing on its own. We need to go in, find the exact site of the blockage, and either cut away the scar tissue strangling it, or bridge the gap before the target muscles permanently die.
And the surgery for a cut nerve sounds incredibly delicate. The text mentions repairing sharp cuts directly by sewing the ends without tension under magnification.
Very delicate.
We're talking about using microscopes and thread, thinner than a human hair, to connect tiny fascicles of nerves. But what if there's a massive gap? What if a 2-inch section of the nerve was completely obliterated and turned to mush in a crush injury?
If there is a gap, you cannot just grab the 2 severed nerve ends and pull them tightly together to sew them. If you put a nerve under high tension, the blood vessels inside it stretch shut, the nerve suffocates, and it dies.
You have to bridge the gap without any tension.
And surgeons do this by harvesting a nerve graft. They literally steal a nerve from somewhere else in the patient's own body.
The text mentions the Schirol nerve. What is that?
The Schirol nerve is a long, pure sensory nerve that runs all the way down the back of your calf and gives feeling to the outside edge of your foot.
Okay, feeling on the edge of the foot.
In the grand scheme of human function, feeling the side of your heel is relatively expendable.
I suppose it is.
So a surgeon will cut open your leg, remove a long segment of the Schirol nerve, chop it into smaller cables, and meticulously sew those cables into your arm to build a biological bridge between the 2 severed ends of your radial nerve.
So you voluntarily sacrifice a patch of feeling on your foot in order to regain the ability to open your hand. It's an incredible biological trade-off.
It is repurposing the body's raw materials for a higher mechanical calling. It is remarkable surgery.
Truly.
But this brings us to the ultimate, most mind-bending scenario in the entire manuscript. What happens if the 3-month window is missed?
What if it's too late?
What if the trauma was so severe the nerve was destroyed beyond repair? The radial nerve is permanently, irreversibly gone. The extensor muscles on the back of the arm are dead and turning to fat. Is the patient just stuck with a dropped, useless wrist forever?
According to Dr. Senthil Kumaran, absolutely not. And this is where orthopedic science pulls out a trick so deeply clever it almost sounds like science fiction.
It really does.
If the electrical hardware is permanently broken, the surgeons literally hotwire the biological system. They perform what are called tendon transfers.
Tendon transfers.
They take perfectly healthy working muscles from the closing side of the hand, the flexors, and surgically reroute them around the arm to do the job of the dead opening muscles, the extensors.
This is the absolute pinnacle of biomechanical engineering. It circles perfectly back to our core theme from the very beginning. The body is a mechanical system of pulleys.
If a pulley breaks, you just borrow a redundant one from somewhere else.
The text outlines the classic trio of tendon transfers used for a permanent radial palsy. Let's break down this biohack step by step.
Okay, let me make sure I'm wrapping my head around this mechanics puzzle. Step 1. The patient's wrist is dropped. We need to restore wrist extension so they have grip strength.
Right.
The surgeon takes a muscle called the pronator teres. Normally, this muscle sits on the front of the forearm, and its job is to rotate your forearm inward, like turning a doorknob.
Yes.
The surgeon physically detaches one end of it, unplugs it from the bone, swings it over to the back of the arm, and sews it directly into the dead extensor tendons of the wrist.
That is correct. But here is the crucial physiological trick. The pronator teres muscle is powered by the median nerve, which is completely healthy.
Right, the median nerve wasn't injured.
When you detach the muscle tendon, you have to be incredibly careful not to cut its blood supply or its nerve supply. You swing it over like a pendulum on a hinge.
So it's still plugged in.
So now it lives on the back of the arm. When the patient fires the median nerves, instead of rotating the arm, that muscle violently contracts and pulls the wrist upward. Wrist extension is mechanically restored.
That is insane. Okay, step 2. We need to open the fingers. Finger extension. The text says they take a wrist flexor, either the flexor carpi ulnaris or flexor carpi radialis.
Yes.
These are thick muscles that usually pull the wrist forcefully downward. They detach the tendon, snake it all the way around the outside of the arm, and stitch it into the long tendons that run down the back of the fingers.
So a muscle born to close the wrist is now solely responsible for opening the hand.
Exactly. And because humans have multiple wrist flexors, stealing one of them doesn't significantly impair the patient's ability to bend their wrist.
It's a built-in redundancy in our anatomy. You borrow from the rich to give to the poor.
And finally, step 3, thumb extension. You have to be able to pull your thumb away from your hand to grab anything wider than a pencil. For this, they use the palmaris longus.
Palmaris longus.
This is a thin, weak muscle in the forearm that actually doesn't do much of anything. In fact, I remember reading that like 15% of the human population doesn't even have one.
It's a vestigial muscle, an evolutionary leftover from when we used to hang from trees.
But if you have it, the surgeon snips it, tunnels it under the skin, and ties it directly to the thumb extensor tendon.
By rerouting those 3 specific muscles, the pronator teres, a wrist flexor, and the palmaris longus, the surgeon effectively bypasses the entire dead radial nerve.
They restore the mechanical ability to lift the wrist, straighten the fingers, and pull the thumb out.
The patient regains a highly functional opening and extending hand.
Let's just pause to appreciate this. We are literally unplugging biological motors from one side of the machine, physically turning the cables around, sewing them into different tracks, and plugging them into the opposite side to reverse their function.
It is the ultimate form of anatomical biohacking. It is breathtaking.
It truly is a marvel of surgery, but it leaves us with an incredibly profound neurological implication, which I think serves as the perfect final thought for this deep dive into the radial nerve.
Let's summarize the journey we've taken first before we get to the mind bender.
Okay. We started with the horror of a limp hand dropping a coffee cup. We traced the radial nerve, the great extensor, from the safe junction box of the armpit, spiraling dangerously bare around the humerus bone, diving through the fibrous choke point of the arcata fros, and branching out to power every opening movement of the arm.
We saw how a deep, drunken sleep over a chair on a Saturday night can suffocate the nerve.
And how the loss of this single extension cable mathematically destroys the mechanical leverage required for a strong grip. We learned that neurologists diagnose this not just with needles that sound like rain, but by physically reading the living circuit diagram of the patient's moving limb.
And we saw that the treatment is an escalating ladder.
Right, from simple patients with a plastic splint to prevent frozen joints, to microscopic nerve grafting using a piece of your leg, all the way to surgically rerouting tendons to hotwire the anatomy.
It is a phenomenal system. But here is the ultimate question regarding those tendon transfers we just discussed. Think about what happens the moment after the surgeon wakes the patient up from anesthesia. The surgeon has taken a flexor muscle, a muscle whose entire evolutionary purpose, mapped in the brain, is to close the hand, and physically moved it to the back of the arm to act as an extensor.
The physical hardware has been hacked.
But the brain's wiring, the software hasn't changed at all. The brain still firmly thinks that muscle is a flexor.
Oh my God.
Right.
Right. If the patient wants to open their hand, the brain naturally fires the radial nerve, but nothing happens because the radial nerve is dead.
Exactly.
To make the new borrowed muscle open the hand, the patient literally has to think, I want to close my wrist, to fire the median nerve, which then mechanically pulls the fingers open. It's completely backward.
It's entirely backward. At first, it is incredibly clunky. The patient has to sit in physical therapy, staring at their hand, and consciously force themselves to think close every time they want to let go of an object.
Wow.
But here is the absolute miracle of neuroplasticity. Through grueling physical therapy, repetition, and sheer willpower, the human brain literally rewires its own software.
It updates its own operating system.
It updates itself. Over time, the patient stops having to consciously think close to open. The brain completely remaps its motor cortex. It learns to intuitively and automatically fire a flexor command when it simply desires to extend the hand.
The mind adapts to the hacked machine so perfectly that the movement becomes entirely natural, subconscious, and fluid again.
It does.
It forces you to wonder, if our brains can completely remap the fundamental physical concepts of open and close just because a surgeon moved a piece of biological string from the front to the back of our arm, what are the true outer limits of human neuroplasticity?
How much of what we consider our fixed physical reality is actually just flexible software waiting to be rewritten?
It suggests that we are far more adaptable than we could possibly imagine.
That is an incredible thought to end on. Our bodies are not just rigid biological destiny, they are highly adaptable mechanical masterpieces.
Thank you all for joining us on this deep dive. Next time you reach out and open your hand to grab that cup of coffee in the morning, take a second to appreciate the incredibly complex mechanical ballet of pulleys, electrical cables, and biohacked software that makes it all effortlessly possible.